Alonia, maybe would be the best if you start with the instructions.
Sure. I will speak a few minutes. Thank you so much.
Victoria?
Zoran, are we ready to start?
Yes, please.
Welcome to these two webinar series that are organized with the initiative of ESTSS for Ukraine. Those two specific webinars are in collaboration with the Italian Society of Traumatic Stress Studies, and of which I'm the president. And the title is Trauma Spectrum Disorders in Acute and the Post-Acute Phases, with a specific focus on narrative exposure therapy and on a protocol that was derived by narrative exposure therapy that is more geared to acute phases. So my name is Vittoria Ardino. As I said, I'm the president of SIST, and I teach psychological trauma at the University of Urbino, and also an ESTSS member. And I'm very pleased to have with us today also Maggie Schauer, that probably most of you know already, and I let her to introduce herself before we kick off.
Hello, I'm really excited to be here, and I'm very happy to join the effort of our Ukraine colleagues in helping trauma survivors. My name is Maggie Schauer. I'm a psychotraumatologist from the University of Constance and Vivo International, and I'm happy to as well be now on the board of the SIST of the Italian Society, as Vittoria said. So together, I think we can support many survivors in this way.
So just to give you a very brief overview, I don't want to steal too much time to Maggie for her introduction today to narrative exposure therapy, but the idea is really to show you a bit the connection between the trauma treatment principles that are embedded, and Maggie will talk about this in NET, and what can be done deriving from this protocol in the acute phase that we are going to see on the 25th as the second webinar. And that is a logic, that is the second webinar, because the protocol I'm going to introduce to you is really directly derived from NET. So basically the idea is how can we think in terms of a continuum about optimal strategies that we could adopt. And as you know, the literature in psychotraumatology is really rich about this. How can we work in post-acute phases to facilitate the integration of traumatic memories and to heal post-traumatic consequences? And also, how can we reflect on optimal strategies to assist the trauma survivors in the immediate period following trauma exposure, with the goal of preventing as much as we can post-traumatic outcomes in the long period, or at least to mitigate some of them. So the idea to share that is behind those two webinars is to give you how can we use early intervention derived from trauma-focused therapy, hopefully to give you an idea of a continuum about this. And this is also directly related to the debate, the ongoing debate about phase-based treatments, standing alone trauma-focused. How can we use stabilization in acute phase? And also, how can this be seen as a continuum in terms of exposure-based therapies toward an integration that can be operationalized? So the goal is to see how early of a trauma-focused therapy. I'm sure Maggie is going to talk about this today. So how can we use this basically idea to guide through this exposure from the past and the present among the traumatic networks, and how can we use this very effective work into also early intervention? And the common goal is to work from a different perspective, on explicit and implicit memory, as we are going to see. And here, just to give you an idea that among the similarities and differences among the two protocols. So today, Maggie is going to talk, of course, about narrative exposure therapy. And in the second webinar, we will see how this has been modified to use a protocol without exposure that could be used in acute phases. But many of the things that you're going to hear today, you're going to hear them slightly modified in the next webinar. So there is a continuity and an overarching similar framework that we are going to propose to you. I'm going to shut down and I let Maggie give her presentation, and thank you very much for attending our webinars.
Thank you, Vittoria. Don't shut down. Shutting down is a really severe situation in trauma, so I don't recommend you to shut down. Yeah, my task is today to introduce a bit narrative exposure therapy. And to do that, in order to do that, I need to give you some framework. Where among the brothers and sisters of trauma interventions do we place narrative exposure therapy? Where does it come from? And how do you do it? How do you apply it? If you need to write to me, please note my email. I'm happy to respond to you and send you material in case you want to read further or use some of the material I'm going to talk about. Here is our vision and mission statement: overcome and prevent traumatic stress, safeguarding the right and dignity of people affected by violence and conflict. And unfortunately, violence and conflict situations appear now in Ukraine, in the middle of Europe. In order to understand what happens when you get stuck in a traumatic event and why it's never over, I would like to introduce you a bit to the few steps in trauma, in memory theory we need in order to properly apply narrative exposure therapy. So people who have been traumatized and who end up having a trauma spectrum disorder, they are not with us in the present situation. They really, their whole consciousness, their whole mode of being, even their physiology, their organism responds to the past and not to whatever reality has to offer. When we look at what happens during trauma, and I think I will slow down a bit in order to allow translation. What happens during trauma is the first thing is we freeze and attend to the threat. That is really important to us. The next thing is only that we try and avoid it, try to flee. And only stage 3 is then the idea of fighting back. It depends a bit on your age, your gender, your previous experiences, how you react to a traumatic threat or to a threat to human life. But the sequence, the first steps in sequence are as demonstrated on this slide. So we have a really high activation, physical activation. Our heart rate goes up, our blood pressure goes up. And while we are getting so excited, there is, of course, a high motivation going along. Lots of emotions. And whenever we have emotions, we build memory. No memory building without emotional support. So fear is a strong driver of building memory, and those elements that appear, evolve in that moment, they are tied together in that moment as an associative network. Later, we call it a fear structure, and it consists of all the different levels of perception, cognition, affect, emotions, and then even physical awareness, physical sensations from inside the body, somatic sensations. And we will have moments of meaning, like what this means, what's happening here. And this is to get tied together in neural networks. We know a lot about them. Today they are well studied and they tend to be bigger and bigger. So now when you go up this activation, you reach a point that is called alarm response. And most of the survivors who see a threat, encounter a threat that really makes them helpless and fearful, in terror. This is a girl on a slide. It's just too fast. So she actually goes into a state of tonic immobility. Tonic immobility means that you can't move anymore. You really grow stiff, can't talk anymore, you can't scream anymore. You're in a way unresponsive, and you're not trying to flee, not trying to fight this threat anymore. So this stage is going along with high palpitations, with a tachycardic situation. It's the highest point of activation, which we call fright. At this point, our memory structures fall apart. The amygdala, which is able to store sensory elements of the event, the functionality increases, like what we smell, what we hear, what we see, what we feel, and so on. The hot memory content, but in the opposite, the function of memory features that store cold information, like contextual information, is going down. So this functionality declines and our memory is falling apart. On this level of stress, we are in a situation where our different traumatic incidents and their contexts cannot be voluntarily retrieved anymore later. You will have many of those elements that are tied together and that elicit each other in a fear structure, but you cannot voluntarily retrieve anymore the context situation. That's why we start reliving the traumatic sequences without knowing where we are and without having time and place for them, tying them back to time and place. If you continue on the defense cascade, even later stages appear that make it hard to retrieve memory later. The next stage would be flaccid immobility. In many war situations, you see people collapse. People are having some syncopes or pre-syncopes. So at that point in time, your heart rate is going down, you're having your blood pressure is going down, and you're getting flaccid and weak. And you can't fight and flee anymore because now you're not tense, but you're weak. This is like the latest stage in the whole defense system. So you see that it's difficult for our memories to keep up with what's happening. In a war situation, we do not only have the moment of fleeing a threat or one moment of threat, we typically have a pre-flight situation that is difficult. Like, for example, in Ukraine, in the eastern Ukraine, since 2014, numbers of PTSD are rising. We have studies that show that up to 12 to 20% of the population are actually already suffering from post-traumatic stress disorders before the current war started. So you typically have in situations of organized violence in countries where later there is a stage of forced migration, you have violence and a tumult situation going on. You have many threats to human security. You already have a lot of family violence when families are under pressure. And only then later there comes this acute moment, and there comes the flight with all the dangers attached and all the threats, and then you're in a refugee situation in the exile with many other stresses. So it's not just one stressor we are facing here, it's multiple stressors starting early. That's why we today talk about continuous trauma environments more than we talk about monotrauma or multiple trauma. Many people in the world live in situations where stressors and threats to their life and integrity are daily. If you look at the post-migration phase, it's not easier. Here is a young boy in a German shelter, very tired. You have a lot of stresses, even though you reached a situation of security. These stresses build upon each other. We call it the building block. So it's not just one stressor, it's a life event, it's a traumatic stressor, it's all the conflicts that build up, that pile up. And you can see that the more stresses humans survive, the more sick later they are physically and mentally. So if you live in a continuously stressful environment, you're much more likely to suffer from physical illnesses and mental illnesses. We've looked at the population of 3,500 people who were forcibly displaced. And here you can see that humans can tolerate up to 28 different types of traumatic stresses. But then at that point, 100% of survivors suffer from trauma spectrum disorders. So you can survive quite a number of adversities, but everybody breaks at one point. And that's the situation we are facing, and that's the situation we have to be careful about when we talk about interventions for trauma survivors. So you can see that different events like a motorbike accident, beatings in the childhood from a stepfather, a rape by the neighbor, and an explosion of a war event, all these different events are not important anymore when it comes to their context. It's what's left is a lot of fear and arousal continuously. We lose the context. So in a very schematic way, I would like to illustrate what happens. These fear networks, they grow and grow from different events, and they are decontextualized from the reality and from your cold memory contents. So you're actually stuck in your fear network. Today, we talk a lot about cascade models of care, so that we go in different steps to provide interventions. And these are the most important ones. Just to summarize, you want to protect against harmful stress, stop the stress, and remove survivors from stressful environments where they could be further harmed. You want to support recovery, really make sure that barriers for recovery are removed. You want to provide for the vulnerable, for those people who are really suffering and who really need help urgently and later in the post-trauma phase. And you want to identify spreaders. We typically forget that our stress axis is built when our grandmother is pregnant with our mother, and then the mother with us. And all those environments contribute, as we know today, to an epigenetic shaping of our stress response. So these transgenerational cycles are really important, but my talk today starts with the individual life, starting with the individual life. Typically, care is really on these in these pyramids organized. So first, of course, you want to make sure for life and survival, and for family reunion, and for the basic health care. And very soon, you want to introduce economic opportunities to regain status and dignity. And only the top part often is occupied with mental health. It's just the tip of the iceberg. Actually, mental health is important for all of the levels. But the way we look at it today is really very poor, just to think that mental health is only at the tip part of this pyramid. So what is the evidence that we can intervene effectively? Which factors do we have? First of all, you want to identify vulnerable people. This is survivors of NET who are acting out, who are really anxious, who can't calm down, or who are still in an environment of stress. Then, of course, you want to attend to children and youth because they're really dependent on their caregivers' mental health and on their caregivers' stress axis, obviously. And they need early and adequate intervention if there is a challenge. Then you want to identify spreaders. Like in a pandemic, there are dangers of spreading trauma through high affect, for example, in your social environment, through aggression in your social environment, and, for example, as I've briefly shown, when you are pregnant. Now, the second step is psychological rehabilitation for those who need it in a psychotherapeutic intervention. There was a ISTSS talk like 2 weeks ago, and Professor Sibrandi and Peter Wentevogel were talking about the intervention pyramid that is now widely accepted and is published by the UN organs and by the WHO. There was as well Irina Frankova there, who gave a very interesting lecture. So narrative exposure therapy is suggested here as a specialized service for trauma focus. When you look at those care models, the trauma-focused therapies, they need interventions, and you have a top level of very specialized professionals for those who do not respond to these short-term interventions like narrative exposure therapy. I can actually send you all this information in a written form if you like, in case you're interested. So the first important thing is task shifting, and see whether your intervention fits in such a task shifting model, because you can't have professionals for everyone. You will need to work with many lay counselors, with non-professional helpers to join forces and battle this effort, because in a situation where a whole country is at war, or where several countries are at war, and you're really talking about hundreds of thousands of refugees or forcibly displaced people, you need help from people you can include in your system of mental health and psychosocial efforts. So the scaling up of NET was important for us, and that it is a cross-cultural approach, because it's you need to find approaches that are not only for those people who can read and write, for those people who have an opportunity for homework, for formal education, and so on. So it needs to be culturally sensitive and needs to be low threshold. The only thing, or one of the only things we really have as humans that shows to be important to us and how to rehabilitate our events and our memory is indeed that we are storytellers. All the cultures have oral tradition of important events. All the humans share their stories in everywhere in the world. We achieve meaning making by this process, in order to understand what has happened to us. So our stories really define us and the way we understand our group and how we see what has happened to us and how we understand ourselves. This is a picture by Xavier Attaro, a Berlin artist. That storytelling isn't really easy for survivors. You can't speak about it. It has been called speechless terror previously. You cannot find words. Your memory is fragmented. So if in a healthy way, speaking about what happened to you, disclosing to intimate partners or disclosing to your social group is not possible for trauma survivors or for survivors who actually suffer from a pathology after having endured traumatic stress. So we need to accomplish this narrative integration, but how do we do that if people are highly avoidant? You're aware that avoidance is one of the best predictors for chronic traumatic stress, for chronic pathology. So we need to overcome avoidance. We need to put our fragments together. We need to make sense of this experience and come up with a coherent narrative in order to heal. This is actually a picture of the working group of Kirsi Peltonen in Finland. I promised if she borrows me this picture, I will tell every time I show it. It's a young refugee holding stones and flowers. Stones are our symbols for difficult, traumatic, and very sad moments in life. Flowers are our symbols for resources, very positive, successful, beautiful moments in life, and for people we loved and supported us. It's obvious when we see the situation that you need a lifespan approach. You can't just take one event and work on it. That wouldn't make sense at all. You need to overarch what has happened to you from the beginning of your life, actually even what has happened to you previously to your ancestors. Since we all carry those emotional memories in this type of emotional networks connected to each other, they are interconnected with our positive and negative events. We need to furnish a narration that is chronological and biographical. So the easiest way really to work with the survivor is to tell the whole life story, not just pick a piece and work on it. So you really work on the events as they appeared on the timeline. This is why the lifeline has been our symbol for narrative exposure therapy. Here you can see the stones and flowers in the order of appearance and even in size of their meaning. I'll get to this in a moment. So in order to place events back to the past, where they belong in their time, in their space, we start to tell the story from scratch. But the first thing you need, this is what actually is called trauma focus. There's several trauma focused therapies, obviously. I actually don't like the term confronting trauma because it's always connected to violence, to confront something. I really like the exposure, the Latin word, to come out of the position, to expose, come out of the position of a traumatized person while you are narrating. Okay, let's see how we do this. Let me just see whether our translators are doing fine. Okay, thanks. Okay, let me go back here. Yeah, step 1 in the narrative exposure therapy process is to have a face-to-face interview. So we are going to approach trauma material in a structured and gradual way. The first 1 or 2 sessions, and I need to say a session is more than an hour. For trauma sessions, 60 minutes are too short, or the German 50 minutes are much too short. You want to have 90 to 120 minutes to engage with your narrator, to engage with your survivor. So you actually explore the types of traumatic events first on a list. I show you in a moment. And then following this list, you do a structured diagnostic interview, and then you do an explanation. It's written here, allocentric position. What it means is, of course, if you do an interview, you're not yet diving into the events. You're looking from outside, you're looking from the door to the room, you're looking from outside onto your life. So you're doing this interview in a very structured, cold memory type of manner. When, where, who, all the more report-like questions. So when you do a checklist, you actually go along this list we typically have for the typical traumatizing, potentially traumatizing events, and you ask each. When you ask each, you ask as well for when did it happen and where did it happen. Let's see, you have natural disasters, of course, you have fire or explosion, you have accidents that are not intended, but they happened. You have sometimes toxic substances that may change your mind, your brain, your memory system. Then, of course, very important physical assaults, especially important childhood events, and so on. So this is one of the lists, a life event checklist, for example, that has listed one after the other of the potential traumatizing events, and you need to indicate nowadays whether it happened to you directly, whether you saw it or witnessed it, whether you learned about it from a loved one, and as part of your job. Let's say you're a helper, a rescuer, medical doctor, a fire worker, so on. Okay. Then the second list is the childhood events. You always want to do the trauma events and the adverse childhood experiences, because they, of course, lay the foundation for our later mental health. So if you do the list with the typical trauma events, the next step is to the adverse childhood experience that ask for who brought you up? Was there someone you could turn to? Did you have a good bonding relationship, attachment figure? Did people listen to what you have to say? Did you feel a self-worth? And so on. Have you been violated physically? Have you been violated sexually? There are several types of adverse childhood experiences lists. And of course, you can, in addition, do a specific checklist for your type of survivor. If you work with a pregnant woman, you might do a list for the risk for later life risks for the child to be born, that stressors during pregnancy. If you work with a torture survivor, you would like to indicate what type of torture the person has suffered, and all of this in a very context building manner. And so then now after that, you come up with your diagnosis. If you can't do diagnostic conclusions yourself because you're a health worker and not a psychotherapist or a psychiatrist, then you need to involve maybe a colleague to secure your diagnosis of a PTSD or a complex PTSD that has a bit different features, like changes in personality and so on, more deeper feelings of being a failure, of being worthless, and so on. What is always important, and I suggest to do in the first step of NET, is to check whether there is a dissociative subtype. People who have gone through a dissociation peritraumatically and showed shutdown in the way of tonic immobility or flaccid immobility. Those people can be diagnosed nowadays with a dissociative subtype. And if you want to have, this is the shutdown dissociation scale, you can just use it and then see what the results is. And it's a very easy diagnosis to add other comorbidities, of course, as well, like depression, for example. Then you come in the next session or at the end of this double session to a psychoeducation. This is in NET not a very extensive procedure. What it includes really is that you explain to your survivor that these reactions are typical or normal. You explain where they come from. You may even explain the memory disturbance in words that are understandable. It depends, of course, on the age and the formal education of your client. And then after the description of the trauma reactions, you want to introduce what you're going to suggest as an intervention. So in this, here we would explain that we now want to tell the whole life story from the beginning in order to place those events that intrude again and again back to the past. The psychoeducation is is very nicely supported when you use metaphors, like it doesn't help to suppress intrusions because they are like a ball in the water, they will pop up again, or a wound that doesn't want to heal, you need to clean first and then it can heal. So if you use metaphors and pictures, especially for children, then it makes more sense why you should go through a procedure and talk about what has happened. In the next step, we lay out an overview of the life. You can skip this step, but it's very popular by therapists and by clients to look at their whole life for once, to see the whole gestalt, as we say. So again, a double session. You're in an allocentric position again. You're not yet diving in. You're looking onto the life in a special way. When you see the high arousal moments of a life, here it's a sexual abuse in early age, and then typically abused children often experience bullying. I'm sorry. And then this would be stones, of course, here a stone and here. And then this is my auntie cared for me. This would be a flower, for example. Then we have the first love. Who was that? What was his name? Then another stone, a flower here for a birth, and a stone, a grief stone here for a friend who died. And again, a stone for severe partner violence, and then a child in hospital, another stone. So you see that along the timeline, when according to the arousal, the peaks of importance, the peaks that were really important specific events, for those we want to have symbolization. So within the lifetime periods, we have specific events, and those we're indicating. You can do this with flowers and stones, but you can as well do this on a piece of paper and just write it down, note it down. So for all the very important moments, and how do we detect them? We detect them by arousal. Everything that gave us a heartbeat is important. We place a symbol, not more. What happened, like a title of a chapter in a book, and when it was and where it was. That would be very good to locate it. So we come up with such a lifeline where all the important events are mentioned. This is a study with COVID survivors and other intensive care unit survivors who actually, many of them suffer from post-traumatic stress syndrome. but not just because of COVID, obviously, as you see for this typical lifeline, but because there is this building block of many other situations starting in childhood. So at the end of the lifeline, when it's laid out, we take our interview from the first double session, and we check back whether all the events from the list and from the childhood list, from the event list and childhood adversity list is there on the lifeline. If something's missing, we can still include it. And at the end of this, many survivors like to take pictures, or for younger children, it's really nice to draw the lifeline in colors. And you're not just letting them draw, but you narrate along. Now you draw the stone where the war came into your town. This was on this, in this month, and you were this age, for example, and you lived in this town. So interview, laying out the lifeline, and now here comes the third step, and this is now not a single double session, this is over several sessions. So you take each of the very important moments and look into them a bit closer, and then you take the next one, and so on. And this is what I'll lay out a bit now. So now here we come to the narration of the whole life, reprocessing the important events in chronological order, one after the other. And now we are going in an egocentric position. Now we are stepping into the life, and we're really reliving them the way they happen, but from the here and now. So we are talking about them on different levels and always contrast them. This is what I'm going to explain now to you. So basically, in the third step, we are constructing a consistent narrative, but the most important points are those specific events. The therapist supports the reliving and writes down the testimony, what happened there, in a very brief manner. You cannot write down everything, but you can write down in a brief manner what has happened. So you start from birth. Of course, the first 1 or 2 years, we can't remember ourselves. We need a narration about us, what other people told us, or maybe documents. You can include whatever people have rescued on their flight. You can include pictures, or even documents from hospitals or items that children brought along. You let them bring everything to the first session and make sure that you reach to the first traumatic event within the first double session of narration. You don't want to prolong suffering. You don't want to avoid any longer. Now, when you get close to a stone, to a traumatic incident, you realize that the narration changes. There are signs of nervousness, signs of distress. Clients get more speedy. They want to go faster. Even yourself, you realize that it's uncomfortable now, and that you want to speed up, or you want to help the narrator not to go there, in order to, maybe it's emotionally difficult, maybe they suffer when they remember. So the moment you realize that that you are getting nervous yourself as a listener, as a therapist, you have to slow down. Don't go fast. If you speed up now, you can end up in a flashback. It's much easier to digest if you slow down the process of narration and help finding words for every bit and piece. So in that moment, of course, the hot memory associations, they flash up. This fear network is triggered. It takes you to places. People feel things and see things and hear things as if they were there again. And that's why we need to slow down and sort that all out. if you look at the situation, let's say, of this attack with a knife, you have different levels of processing, of course. You have thoughts, you have emotions, you have behaviors, verbally or physically. Our body reacts. This is all a big mess. And that's why we suggest a certain order of exploring stones. So first you start the narration, not in the past, you start in the here and now. You ask the survivor to check in a bit with his own or her own body and to see how they're doing on your chair or on your couch or in your place, on the floor you're sitting and narrating here. And only from there we remember the past, because we don't go there again. Never ever in your life you have to go there again. We're just remembering what happened then in this year, in this month, at that time. So every narration has a beginning. Every traumatic incident has the moment when people felt something's wrong. It's always that there is a moment that arousal escalates all of a sudden. There must be a cue, there must be a start to the situation. So what told you that something's going on? What changed in that moment? Where were you? What time was it? What was the environment? You want to really build up now cold memory information. You really want to contextualize and go from there in very slow motion. What do you see? What do you hear in that moment? What did you feel and smell? And what are the circumstances? What time is it? Where are you? And so on. You compare those two worlds and get them tied together again. They fell apart in the moment of highest arousal. And now you help the survivor to combine them back into a whole narration again. It's always best actually to start your process with perceptions. What did you see, hear, feel, sense, smell, taste? What did your body do? Start with the perception. That's the easiest. And go from there. Because when you perceive something, your thought is the considering of what has been perceived. Let's say you smell, you're in the kitchen cooking and all of a sudden there is smoke in the nose. If you think, that's my oven, then you won't get aroused and nervous. But if you think, oh, this might be my children, they had the matches and I hope they didn't make a fire somewhere, then you're going to be anxious. So first the perception, then the thought to the perception. And this is decisive for how we feel emotionally and what we feel physically and how we will react to this. So first the perception, then the cognition about this perception, then the feeling. What did I feel when I thought this? Because I had this sensation. Someone was touching my body. I thought, this is the perpetrator. He's going to rape me. And now I get scared and my heart is pounding. And this means I'm in a helpless, terrible situation. And I will die. So what did you experience in that moment? What was it? How was it? And when I know what it is and how it was, then I have a precursor for action. Either people tried to flee the situation, terrible situation, or they tried to fight it. And when both wasn't allowed or possible, or would lead to even more aggression, like in childhood when you get beaten, you can't oppose and you learn very fast not to oppose. So then you shut down, for example. Or you're already post-pubertal male and you get very angry and you fight whatever's happening there when you're in a threat. And always make sure for the meaning, not only the big meaning at the end of the narration, really the small meaning of each moment. How can I interpret this moment and what changed? That's a good question to ask. So in that way, we advance the narrative along the timeline, moment for moment for moment. Of course, you stay longest in the more important moment, the more terrifying moment, until the survivor masters a narration and doesn't feel overwhelmed and helpless in that moment anymore. You help really telling the story. Be shoulder to shoulder. See what your narrator sees. If you can't see as a listener what they have gone through, you're not detailed enough. Be emotionally very close, and then you paraphrase and you summarize and you give back what you have understood again and again, so that the other person doesn't feel left alone while they are talking to you, while they are narrating to you. Just to make sure that you're not taking in this moment a non-directive approach, because the avoidance as a core part of a trauma would lead you away from this very important moment. So you need to be directive in a sense that you're guiding along the timeline. And if you're doing this, you can't harm the person. It's a very robust procedure, and even lay counselors with appropriate training can do that. You just stay along the timeline of the incident. So to make sure that you're doing the right thing, I'd like to show again what the core task is when you do narrative exposure. You're talking about the trauma back then, and you're always comparing it to the here and now. At the time, I was horrified, I was screaming. Here I'm sitting and telling you that I was horrified then. It feels a bit like then, because I remember intensely, but I'm not there. So the therapist really modulates the arousal and takes the survivor back and forth in a pendulum motion. Many trauma-focused therapies do that in different manners. Sometimes you tell it again and again until it gets more easy and detailed. Others help with visual stimulation or sensory stimulation to be in the here and now. In narrative exposure therapy, the therapist consciously invites the narrator to go and come back to the here and now, and then we go back to the moment and we compare what's going on. And every now and then it's really a matter of respect, I think. You allow the person, when you come to the here and now, that they can reflect on your process. So how is it for you to see yourself in the past? To see yourself as a little child left alone, or being raped, or being physically violated, so that survivors start connecting to their younger self and supporting themselves. So this is me narrating the situation, being in the here and now, and being back then. And that's the way how we are advancing. And you can be very concrete and say, there was this yellow car you crashed into. Is there something yellow here in the room? Yeah, maybe the picture, but it looks different. There was this noise of the bang and the glass splittering. Here it's silent. I just hear birds. I was so fearful and horrified, and I thought I get stuck in this car forever. Here we can invite the survivor to move on the chair in order to convince the body that we are out of the situation. So if you invite reliving, but only as if, and come back again and again, this is a very stabilizing procedure, so that people don't get overwhelmed, don't get flooded with too many informations at a time, or taken back to a flashback. You have to make sure as a listener to your narrator, that this person feels safe in the here and now, just remembering. Once your exposure session is finished, and the arousal has gone down, not because your session has ended and you are out of the session, but because you talked long enough and concrete enough, and you really gave every perception, every cognition, every emotion, every physical sensation, and every meaning moment words, then the person can calm down. And it's very obvious when you're doing this work and you stay long enough at the painful place, and the person finds the right words and can limit and frame the event. Because when you find the right words to describe what has happened to you, then the reaction really is relieved. So at the end of this process, and obviously at the end of the session, you make sure that you, along the timeline, that the event is really over, that it's a day or a week later, and that the people feel relatively safe. They're never perfectly safe. Life is dangerous, but relatively safe, and the event is over. You can say goodbye, and between the sessions, the therapist writes up and structures the narrative. Whatever we have taken, the little script we have taken, we put in a sequence and we make a story. And I think it's very validating, not the client, not the narrator is writing it up, but the therapist for the narrator. And we come back, the beginning of next session is a greeting and a short wrap up what has happened during the week. And then we read out the transcript. And we do it in a co-constructive way, so that the rereading is really that you invite the survivor a second time to engage in this narration. So you would read a bit, then you would ask, did I write it correctly? You want to add something? And then whatever's popped up during the week, whatever is important to include, you would include in your account. The rereading actually is a very important step for validation, because here the survivor really experiences that you listened carefully, that you heard what they told you, and you even made a story out of their words. So that's the way we continue in working through important events, rereading them as well. The flowers. Flowers are very important, but always take a specific event. If someone said, my grandmother was the only person who loved me in my childhood, then take a specific moment where this love incorporates. Like the day that I celebrated my 8th birthday, she made a cake and they gave me a beautiful dress. So you work on that situation in depth, and you feel again the love, and you feel the appreciation of this person. It's not obvious that flowers are always positive. Many of the flowers are just positive because there was an absence of a lot of good things otherwise, or because we had a hard time before that. Let's say you're in labor and you're in pain, and then finally your child is born, or you had to learn a lot for an exam and only then you passed. So there is often a mixture of negative and positive feelings, even in flowers, but they are important to us. And we really want to remember them. And flowers which end positive, of course, this feeling doesn't end in the session. We can give it as a present for the survivor at home and forever after in the life. Now, at the very end, you can either reread the whole testimony, or you lay out a lifeline at the end of your treatment sessions, which is typically 6 to 14 double sessions. It depends, of course, on the amount of events, and it depends on the age of the survivor. If a person doesn't speak your language and you're working with translation, you should always read the document. always read the testimony. I think it's a matter of respect to really read it back to the person and translate it again. And then you want to discuss what's going to happen with this testimony. Do people want to take it along? Do they want to use it for some human rights work or other issues? Or does it stay at your place on a digital version for some time, let's say? Okay, we do hand it over, we sign it. The narrator, the therapist, the translator, and often a student. So we're always kind of a small group working together. Everybody signs that he's a witness to the account of the narrator. This step of advocacy has been discussed a lot in the 70s and 80s, whether we should actually at all talk about pathology after a traumatic event, because the survivor isn't pathologic, it's the perpetrator, really. So since the trauma spectrum disorders are a disorder and a pathology to the memory and the brain, we can't neglect this part. But in the same time, we want to make sure for the dignity of the survivor and for their chance to empowerment. And this is why it's much better to take a testimonial approach and not so much a medical approach that something's wrong with that person. The provision of justice, even if it can't take place in a juridical manner, it's still a lot of respect that if you counteract forgetfulness and denial, and this can even be done in a group format. NET has been developed further to NET facts, where you have whole villages or social groups laying out their lifelines and sharing their stories in an anonymous way, and then it's read out to the group so that everybody learns what actually has happened and survivors are no longer neglected. Here is an overview over the procedure of the 3 steps and the final step of handing the document to the survivor and closing the session with a ritual. For me, or what we know about NET really, it's a module. You can do different things before, different interventions. You can do other interventions afterwards. It would just be good, or what we have evidence for is if you use narrative exposure therapy as a module, then do it according to the manualization and not stopping it, doing different works and then continuing. People often like the lifeline as such, but we do not have evidence that the lifeline alone is a good rehabilitation measure. If you use it properly, then we have evidence that this chronological reconstruction of this autobiographic memory is beneficial, that we should take care for a meaningful linkage and integration of these events into the past. And what is really important is regaining survivors' dignity and acknowledgement, a chance for acknowledging what has happened. And for complex trauma survivor, of course, it's their attachment wounds that can be healed that way, because the moment you're in that situation again, now here is your careful listener, here is your empathic therapist, and this time you're seen and you're answered and you're validated. So make sure that your survivors of complex childhood trauma get a chance for reparative attachment situations. Thank you very much.
Maggie, I see that in the chat there are quite a few questions.
Okay, should I answer them? I can see I can see some of, I can see a question and answer question. If you allow me, I would
there
just
is,
answer.
also, for example, a question from Maya saying that whether you can use NET treatment online. That is one of the questions.
Yeah, we have 2 new papers, and the first studies that show you can do ENET, electronic net, just the same way. You cannot use, of course, stones and flowers, but we have possibilities to do online stones and flowers, or at least write the lifeline, but it's just the same. It has some advantages and disadvantages. Of course, you're not in the same room, but it's really interesting, Maya, because you can see each other very well. You're really close, seeing the different features of the mimics. And if your network work, your digital network is good enough, we really have very good success. So don't hesitate. It's a great opportunity. It's so much better for our ecological footprint. It's so much better to reach out to really everyone, even people in resource poor situations who couldn't travel, or for severe symptomatology where people don't want to leave their house, have a hard time because they're dissociating all the time. Yeah, I really like to encourage you. I can send you the papers if you want. I just saw that someone wanted again for me to write my email. I write it down for all of you, and then
they put it down earlier again, but you can put it again.
Oops. There are several. Okay.
I can group for you a couple of questions
Sure.
that I read as you were presenting. A first one that came before was whether NET could be only delivered by psychologists or psychotherapists. The other question was what is the difference between individual and group intervention, and whether, another one was whether you considered to use NET in combination with EMDR.
This is three completely different questions. So I think the first one you asked whether it it was the second, in a group format. In a group format, you can do it in according to what I said in the last part, NET facts. This has a group component, and you lay out, for example, you have individual interviews, and then you lay out a lifeline together with the group. But then those who really suffer from symptoms of PTSD have an individual treatment of their main event. And only then they come back to the group, and then you read back accounts, anonymous accounts, so that everybody knows what has happened, but that you don't point out people who was it. So this is a group format. You cannot restore traumatic memories in a group format as such, because everybody makes a different meaning moment. Everybody has different perceptions, cognitions. First, for people who are really suffering from a trauma spectrum disorders, they first need at least some, we had studies with 4 double sessions of individual treatment. The other question, would you recommend a combination of NET and EMDR? I have to admit, I can't tell. I don't know of any evidence of combinations. I don't even know of a single RCT that compares EMDR and NET outcomes. There has been RCTs with in comparison to other interventions, but I don't feel safe to suggest a combination where we don't have evidence. We will have to wait until we come up with studies, I guess. And as I said, if you want to use NET, or probably if you want to use EMDR, I guess, you want NET especially, do it as a manualized version, do all the steps. And I just see that someone, Christabel, asks whether I could go back to the slide where you see the overview. Am I allowed to share screen again? Victoria, just show this slide. But I can actually send you the, I think you mean this one, right? Yeah. I can send you the paper if you want. Okay. The other questions I can't see, Victoria. Could you help me?
Let's see. I can have a look for you.
Thanks.
Let's see. Oh yes, there is one question. What could you do if the person wanted to talk in detail about the events during the diagnostic phases, during the interview stages? What could you do in that case?
Okay, a person who wants to talk in detail is not a traumatized person, but that's not a serious answer, because you have avoidance. People won't like to talk. But I see what you're saying. There are some people who immediately want to release their pressure. What you tell people is that today we're just collecting what happened to you in your life. I brought a list from other people's experience and we see what applies to you. And then we go in a very structured way so that you really benefit from this procedure, that it's not too much, that it's not overwhelming for you. And if you have an incident that you really want to share immediately, then we should for sure make time in a whole session, because this seems to be a very important one. So really encourage people and tell them to wait a bit, because specific important events deserve specific sessions that we can look at them in detail. What you can always do to allow people to talk about, of course, I mean, they are the masters of their biography, and who are we to tell them that they are not capable of or not allowed to talk about it? They can of course talk about it, but you may explain to them in which way it's beneficial. If we don't have the time to go in depth properly, we ask them to stay on the factual, on the cold, on the context side of things, like a police report. You can tell me what happened, but more in a way of the interview and the lifeline. How old were you? What was it? How would you call the title? For example, I was raped when I was 14 years old in Munich, going home at 3 o'clock from a party. This is a version. You can put a sentence and then you say, okay, now we know what happened, when it happened, where it happened. We built a bit of a context, and to look into this event, how this affected you emotionally and physically, and in your meaning outcome, we need to have more time. That's the way how I would explain it. Yeah.
Maggie, one last question before we close up. There is, what can we do as paramedics when a soldier is in a tonic immobility while being in fighting area?
Yeah. Okay. So that seems to be an acute stage now. We are not post-traumatic when he's talking about it and repeating the situation, but while he's there. When a person is going into tonic immobility, we have a deafferentation of sensory information. That means sensory information can't travel through the thalamus to the brain anymore. So people have a hard time hearing us, seeing well. They seem that everything is like further away. Even if we touch them, they feel numb. They are very aroused. So what you have to consider is to slow down what you say. Speak very clear like a paramedic. Speak few sentences. Speak loud enough, so above the threshold that they can hear you. And a very good thing is if you address them by their first name. We often don't attend to our second name, like Schauer. I wouldn't attend. If someone says Maggie, I'm much more likely to attend to that voice. So to bring that consciousness back into the here and now, you address them with their first name and you try to stimulate their perceptions, because you know in the back of your head that sensory processing is difficult. You can ask them whether you can touch the hand. In some cultures, you can't touch the hand, you can only touch this part, and address them so that you stimulate the sensory information going up to the brain. And what you want to do in this stage, you need to bring down the arousal. The arousal is too high, physical arousal. So whatever helps to bring down the arousal is beneficial when there is tonic immobility. You can invite his comrades, one of his comrades who knows him well, to sit by his side, to talk to him, whatever is helpful to bring down the arousal and to stimulate the awareness in the here and now.
Great. I think we are coming to an end with this first webinar. Thank you very much, Maggie. That was brilliant. And
thank you, Vittoria.
Thank you.
I'm looking forward to your contribution next time.
Thank you.
I'm really curious.
And thank you for all the participants. So we see you all again on the 25th, and thanks to the ESCSS for putting all these things together. Many thanks and have a good evening.
Alonia.
And thank you, Alonia, for the translation. Yes, thank you very much for the translation.
Good luck, everybody.
Good luck. Bye.
Bye.